Hi everyone, I'm back. We are still on the same familiar topic, heart attack. Okay, my uncle just asked me the question, can the pump be rejuvenated after the attack? Oh, let's see if I'm able to provide a reasonable answer. The heart has just been sorted, the heart has just been attacked and has just been treated from the emergency room. The wonderful doctors and nurses, they've done their job, the good patient has cooperated. Congratulations to everyone on the successful initial treatment. But hello, not the end. We have more to do for my father or for my uncle. In other words, post myocardial infarction treatment. Okay, was percutaneous intervention done in this patient who had ST elevated myocardial infarction before? If the answer is yes, okay, fine. We'll do EKG and echo now. What is the left ventricular ejection fraction? If it's less than 95, okay, ICDs should be in place right now. If the heart is raising, there's arrhythmia, like atrial fibrillation, then I have to choose between non-dihydroprotidine calcium channel blockers called diazepam or beta blockers. I'm not going to leave this man to go home without finding a way to block any possible thrombus again. So I'm going to put this man on clot busters. Warfarin is available. How about antiplatelets like combination of aspirin and clopidogrel? Clopidogrel has been around for a long time, Flavis. But now ticagrelor is on, so I can just add aspirin and ticagrelor. Let's repeat the lab. Let's get a new result. What is happening with the cardiac enzymes right now? Give the statins. I'm not going to stop it, particularly after lipid profile. Let this patient be on beta blocker if there are no contraindications. Angiotensin converting enzyme inhibitors, ramipril is excellent, particularly if my uncle has diabetes mellitus as well. Continued nitroglycerin as may be required for discomfort and pain. Correct conditions like all modifiable risk factors. Watch the weight. Remove stress. Be lively. Be funny. Play around. Don't play a fool like a fool. Give anxiolytics to suppress the anxiety. And if you have noticed depression in this person, don't let him or her commit suicide. Place on selective serotonin reuptake inhibitor. And all other necessary steps. No percutaneous intervention has ever been done in this patient. Why? He had non-ST elevated myocardial infarction, or he actually had ST elevated myocardial infarction, but because my center didn't have cath lab and the brilliant doctor to do it, we gave thrombolytics. Now, what am I going to do? I'm going to consider what we call rescue PCI in this patient who had ST elevated myocardial infarction, but the thrombolytic agent, my RTPA, has failed. It has failed because it has not led to a full reperfusion. Also, I will now consider percutaneous intervention in this patient who was initially diagnosed with non-ST elevated myocardial infarction or stable angina because he couldn't receive thrombolytics because they don't take it. We don't give them. So PCI now. But why will I go for PCI right now in non-ST elevated myocardial infarction or unstable angina? If they are now having recurrent chest pain, we have done the echo and it's revealing that the left ventricle is not working properly. There's left ventricular ejection fraction that is less than 35%. This is an unstable patient because the vital signs is showing that the BP is on the downward end, that is hypotension. And exercise stress test reveals that this patient is not stable. That's high risk here. Then I'm going to call for PCI right away. Or transfer to another center where the PCI is available. Okay, we've done everything. What am I going to tell this uncle about possibility of complications? It's possible that the attack could be recurring myocardial infarction. Some patient will tell you so many stories that I've had this 5 times, 6 times. They are not lying. It's possible. It's possible to be recurring. There's possibility of shock or congestive cardiac failure within 2 days. Within 2 days. I said, oh, he was fine. He was fine when we were together on Saturday. So why is he now saying today on Monday that the doctor has diagnosed him with heart attack and is having heart failure? It's possible. Papillary muscle rupture, and there will be hole in the heart called ventricular septal defect. There's possibility of arrhythmia. The heart is not beating properly again. Now, tachycardia or bradycardia. Post-infarct angina is very common. Deep vein thrombosis and thrombus, causing all sorts of troubles. We'll talk about them later on. There's possibility of inflammation of the layers of the heart called pericarditis, and of course, Dressler syndrome in the long time, in 2 to 8 weeks time. So we are still going to talk more. Thank you for watching my video. We will end this series very soon. Thank you very much. See you soon.